Hello, Ignacio.
Hello.
Hello.
I am very sorry for my delay connection. I had a primary TAVI case. Patient
No
in.
problem. No problem. No problem, Ignacio. Well, I think we can start right now. I will make a short introduction. Well, thank you everybody for attending this webinar. I'm Juan Serrano. I work in Pros and Features. And the intention of this webinar is to go through the insights of the Tricus share study. So let me introduce Dr. Ignacio Amat. Ignacio Amat is one of the main principal investigators of the Tricus year study, and recently he has published the one-year follow-up data of our patient population in the JAC interventions journal. So the intention of this meeting, as I said, is to go through the results from patient selection and also to know how can we, let's say, show this data and add this, let's say, this result, or what can we take home message from the clinical practice from this study. So Ignacio, please, the floor is yours.
Thank you so much for your kind presentation, Juan. For me, it's a great pleasure to share with you the results of this multi-center study. Can you hear me properly?
Yes, we can hear you.
So the concept of trick valve is trying to avoid this, trying to avoid the backflow towards the superior vena cava and the backflow towards the inferior vena cava. So it's an orthotopic therapy whose target is to abolish backflow. But is this mechanism enough for the outcomes of our patients? This was not known. There was the feasibility sort of study. But of course, the question that I got asked and all the people who is implanting got asked is, which is the long-term prognosis of these patients? Having a series of patients, that is a short series of patients, but with 1 year follow-up is starting to provide us with some insights on the true outcomes of these patients. This therapy is very controversial because it's a heterotopic concept. Then, which is the impact for the patient? Is this futile? Is this useful for the future of the patients? This is why we try to be very careful in gathering all the clinical data of our patients up to 1 year follow-up. You know, the preliminary data were published for 64 patients. In this study, there were 12 centers included from Spain and Austria. It was prospective, non-blinded, non-randomized, so it was a single-arm study of very symptomatic patients. And the follow-up is pre-specified at 3 months, 6 months, 1 year, which is what I'm presenting now, and up to 5 years. And of course, during the next 2, 3, 4, 5 years, we will need to report the outcomes of these patients to understand if this is truly useful for our patients. So this feasibility and CE mark studies put together sum up 44 patients, which is what I'm presenting now. And the primary endpoint was functional outcomes. How was this measured? It was measured by improvement in quality of life as assessed by Kansas City Cardiomyopathy Questionnaire, improvement in New York Heart Association, and improvement in seismic walk test. Of course, we also paid attention to other secondary endpoints as major adverse events, imaging parameters as right heart dimensions, clinical parameters as improvement in congestion by echo, assessing the inferior vena cava, by lab, assessing the liver function according to the blood test, and also changes in the renal and hepatic function. These are the baseline characteristics of the 44 patients. The mean age was 76-year-old. This is mostly a disease affecting women. And the TRIE score, which is the score that we use to assess the surgical outcomes in these patients, and because Euroscore or STS score are not very accurate, TRIE score was very high. So it was a very high risk patients. If we pay attention to some other parameters, we can see that 20% of the patients have the prior pacemaker, that 66% of the patients have chronic kidney disease, and that a high proportion of these patients had a prior valve surgery or a prior percutaneous therapy in some of the valves, including one case with a prior edge-to-edge in the tricuspid and 3 cases in the mitral. This primary endpoint based on the clinical improvement in symptoms was met in 95.5% of the patients. To be more specific, describing this at 1 year, this was referred to an improvement of at least 15 points in the Kansas City Cardiomyopathy Questionnaire, or improvement to NIHA class 1 or 2 from 3 or 4, or an increase in at least 40 meters in 6-minute walk test. And this improvement is similar to other studies as COAPT for MitraClip or in Partner for TAVI. You can see that the median follow-up was 1 year, so all the patients met this endpoint. If we focus on these specific parameters, the Kansas City Cardiomyopathy Questionnaire in the Tricus 1-year study improved 19 points, and the baseline was 40 points. If we compare with Triluminate, the study with TriClip for tricuspid, we can see that the improvement was similar or a little bit higher, but that the baseline situation of these patients was much worse in those that were eligible for the Tricus study Euro. So we come for a much worse situation in our patients. If we focus on NIHA class, we can see that this improvement in this more subjective parameter started at 30-day follow-up and persisted improving along the follow-up up to 1 year. And regarding the 6-minute walk test, we can see that there is improvement in the patients from baseline 253 to 284 at 1 year, although this was not significant. And we have to take into consideration here that all the cases recruited in the Tricus study Euro were performed during the pandemic, which means that these patients could not walk more. What happened with the medications? You can see that there was not a significant change, but we can see high dose of furosemide, intermediate dose, or low dose, and we can see how this changed. The median values decreased from 40 to 25. 40% of the patients in the study maintained a low dose furosemide. 34% significantly lowered the dose of furosemide, and the remaining patients increased furosemide. But because 23% of them has stopped other medications, as aldosterone or the receptor antagonist or thiazides. For me, the most important finding of this study is the 1-year mortality. To determine if one therapy is futile or not, we have to see if we improve the survival and we improve symptoms. So this is not a randomized trial comparing to medical treatment, but we can say that the mortality is one of the lowest in any percutaneous device that we use for valvular disease. So the 1-year mortality was 6.8%. As a reference in Triluminate, it was 8.8%. And then the other face of the coin is that the rate of rehospitalization, despite this increase in functional class, this improvement in functional class and the low mortality, was almost 30% of the patients compared to Triluminate, where it was 15%. Let's have a look more in detail in this rehospitalization. First, one of the predictors of rehospitalization was prior mitral percutaneous therapy, so transcatheter edge-to-edge mitral therapy. We believe that this might be because these patients with a prior MitraClip or Pascal had already chronic impact in pulmonary resistance, hindering the benefit from TAVI. Also, these patients had worse left ventricular ejection fraction. And finally, we have to remember that after MitraClip, we leave a shunt, an interatrial shunt. If we then implant a CAVI and the shunt is not closed, there can be an inverse of the pressure and there can be a shunt right to left. So this is important to take into consideration whenever we are going to implant tric valve in a patient with a prior left side intervention. We need to check that there is no residual shunt, interatrial shunt, and if there is, we still can treat the CAVI, but we should close this shunt first. On the other hand, we have several studies suggesting that the Kansas City Cardiomyopathy score is not a good tool to predict the rehospitalization rate. And in fact, in patients with right heart failure, this score is not related to the rehospitalization, which is something that we already knew, but there is now a dedicated score clinical score on improvement related to this that we can use to analyze the right heart failure. And finally, we know that when the 6-minute walk distance is below 300 meters, this is correlated with poor prognosis. And in fact, 16% of our patients were not able to walk 200 meters. Most of the patients in the study were in a very poor functional situation, not only because of the right heart failure, but because other problems that limited their capacity to walk. We also have some information regarding imaging. This was published by our group in neurointervention with the 6-month follow-up. And what we found was that there was a positive remodeling in the right ventricle. You can see from baseline in blue to 6-month follow-up in orange, there is a significant decrease in the volume of the right ventricle. And we can also find, that the tricuspid annular dimensions experiment a significant decrease in the dimension at 1-year follow-up. What does this mean? This means that we can use trick valves, we can get an adequate remodeling of the tricuspid annulus and right ventricle, and if the patient remains symptomatic, or there is a leak, or there is some problem with the Tricus trick valve device, we could then treat with edge-to-edge therapy our patient, because the annulus is going to decrease, and maybe a great gap that could not be treated before could be treated after. There were some other findings. We have to remember that all these patients had a pre-specified CT at follow-up. So we could see 3 cases of valve migration. In one of these cases, we could see a leak that was closed percutaneously. And there were also 6 cases of thrombi that you can see here. This thrombi, in any case, affected the function of the trick valve, of the leaflets. It was in the stent. And all cases were related to a poor management of the anticoagulation for different reasons. Sometimes clinical reasons that led to stopped anticoagulation, and in other patients it was due to low range of warfarin, and in all these patients this could be optimized. In fact, this was only found because of the pre-specified CT. Clinically, this was not relevant, and it was not associated to any clinical event. But it's important to know, because we have to pay attention to the anticoagulation in these patients. This is a table summarizing the main outcomes, and there is one outcome that I have not mentioned yet, and is the major bleeding in our patients, which had a relatively high rate, 20%. But it's important to highlight that only 3 patients presented complications related to the puncture site. Most of the bleedings were related to the anticoagulation therapy. These are very congested patients, and we can see that most were gastrointestinal bleedings that could be treated. But there was also a subdural hematoma secondary to an accidental fall, and this patient passed away. This is the mortality here. And there was also a patient with severe epistaxis that required prolonged hospitalization. You can see also here in the main outcomes that one of these patients required surgery, and this was due to one of the 3 cases that presented a malposition, migration of the system shortly after the injury. If we check again the summary, functional status improved in all the parameters that were the primary outcomes. Diuretic dose decrease, NT-proBNP decrease, kidney and liver function were maintained equal, no congestion here. It was 1 death, 30% readmission, and also 9% stroke rate. This is 4 patients, and these cases were unrelated to the therapy, where one was a bleeding event, and there were 3 others that were related to atrial fibrillation or other circumstances unrelated to the device itself. So the main conclusions for me are that the trick valve system has demonstrated safety along 1-year follow-up, with significant improvement in main functional metrics that were used in this study and were comparable to the Triluminate study. And of course, this is only a hint on the potential of this therapy that we will need to analyze in the randomized trial that has already been designed and is about to start recruiting this year, which is the TRICAVI study. There was a very interesting editorial accompanying our article that was presented by Dr. Stoker, and here somehow he pretended to project which is the approach for patients with tricuspid regurgitation. This is also what we are doing in our institution. When we have a patient that is eligible for edge-to-edge therapy, we will consider Pascal in our institution or LIP. When the patient is not eligible, we might consider orthotopic therapies. We know Evoke now has CE mark approved. We are also involved with some other research devices as CardioValve. And this could be a good alternative, but we know that a high proportion of these patients, up to 60%, are not eligible due to large annuli or other anatomical factors. And if we cannot use these therapies and the patient is still eligible for heterotopic from the clinical perspective, because anatomically most patients are eligible, then we will use TricValve for our patients. But I want to add something to this editorial, and is that often we will use TricLip and it will fail early or not so early, or we use another orthotopic therapy and there will be important leakage. In all these circumstances, we can consider TricValve. We can also do the other way. If there is a high-risk patient for orthotopic valve, we might try to treat orthotopically with a TricValve device. And if clinically the patient is not a good responder, then we still can use orthotopic therapies, because the TricValve technology does not difficult the use of orthotopic therapies or other procedures for the left side. So this is one of the main advantages as well. Thank you very much. I am open now for any questions that the audience want to send.
So thank you for
hello, Ignacio. Well, thank you so much for the excellent presentation. I would like to ask you a few questions regarding this data, and try to. I want to know what is your opinion related. First of all, the last slide you show about the algorithms depending what to use. First, repair by edge-to-edge or annuloplasty devices, then orthotopic devices, then heterotopic devices. Which is more or less the rejection rate when you receive a patient? Which is the percentage of patients that say not suitable for edge-to-edge repair and orthotopic devices?
It's a very good question. It's quite subjective because not all the centers work the same. Not all the centers have the same experience. I would say that edge-to-edge is rejected in my center. Well, first, let's consider those patients that we consider that require treatment. There is about 20% of the TR patients that are for medical treatment because it's too late, too failing right ventricle. We have detected that a very dilated right ventricle, even if TAPSI is good, is a very poor parameter for the outcomes because the right ventricular failure is very high. So if we exclude this 20%, there is an 80% remaining. Half of them, more or less, can be treated probably with good outcomes with edge-to-edge therapy. Maybe there is another 20% that are challenging, difficult procedures for edge-to-edge. And then there is a remaining between 30 and 50% that are not good candidates. This is the group of patients that would be considered for orthotopic valves. But when we send these kind of patients for trials, many of them are rejected. The main reason is a large annulus. The second reason is a poor angulation of the inferior vena cava with the right ventricle, because the delivery system has to make a funny curvature, which can be difficult for positioning. So let's say we have 50% or 60% for TR, 10% probably for orthotopic valves, and then there is a remaining group of patients between 30-40%, and probably the best alternative is the bicaval approach. I just want to add, Juan, that there is a tool in Teams. You can raise your hand to participate, so we can moderate the session if there are any questions.
Now, related to this question, Ignacio, when it comes to talk about, okay, you said that a patient could be suitable or not depending on the experience of the hospital, right? So, but let's consider the patient comes with, let's say, the maximum degree of torrential TR, you know, and based on a previous exam, you know that you can decrease the TR until severe TR, so it's actually 2 degrees less, but not too moderate. Do you think makes sense to try this kind of patients and leave it with severe TR, or the patient will continue to be symptomatic, or will let's say improve in a short term of period, you know, let's say 1 year, and will come back again because it's still severe TR and not moderate?
So in Triluminate, technical success was considered decrease in 1 degree. So massive of torrential to severe, that was success. And when that happened, although in most patients it improved more, but still these patients also improved clinically. So I think it makes sense to try. But if this patient persists to present symptoms, we should not wait another year to consider another alternative, because in 1 year, a residual severe TR is going to deteriorate the patient, deteriorate the right ventricle, and then we are going to arrive late. We are going to have higher risk of acute right heart failure after any therapy, another clip or a trick valve. So if the patient is not improving early after any edge-to-edge therapy, then let's consider the bicabal alternative. This is our approach.
Okay. Thank you, Ignacio. There was a question from Dr. Scholli.
Oh, thank you. I've already got an answer. The answer. Thank you.
Any more questions from the audience?
Ignacio, thank you very much, first of all, for your fantastic...
Yes.
Wait, Juan, just one question. Thank you very much again for your fantastic presentation. I have one question. Considering the small thrombi that we have seen, would you consider a patient that is not eligible for long-term oral anticoagulation to be a candidate at the moment? Or would you stress that the patient should be on lifelong anticoagulation up to our current knowledge? What is your feeling? Because I mean, this is...
Hello, Katarina. That's a very good question, and I'm sure you are making this because you have been in that dilemma with some patients, probably. First of all, when we have findings that are asymptomatic in a control CT, which is not clinical routine, we have to be very careful how we interpret that. For example, in TAVI, when we do control CT, we can find between 10 and 20% of leaflet thrombosis, so clinical thrombosis, what is called HALT. So what do we do with that? We still don't know. We know that that does not have an impact in the outcomes for TAVI, in the clinical outcomes, so we don't know how to manage. So here we have the same situation. We have found some thrombi in the right side, not clinically relevant, and the question probably is there a risk of progression to leaflet thrombosis? I think in the right side, risk of thrombosis is higher because pressures are lower, so there is lower cleaning of this blood stagnation. This is one factor, and then these are very dilated chambers in many patients. So probably if a patient cannot be anticoagulated by any drug, I think I would avoid for the moment treating them, because if there is a leaflet thrombosis, this can lead to a deterioration in the clinical symptoms of the patients. So I think I would be conservative for the time being. But if there is any kind of compassionate cases where they use them, I think anyone who does a case like that should report the outcomes.
Absolutely. I think this is something that we should also ask the community to report cases where anticoagulation had to be stopped and where they probably have to have a more intense control by echo or even CT. Thank you very much, Ignacio. I think it's very important.
We have a lot of participants, but they are a bit shy. document.
Considering it's okay. Ignacio, one last question from my side. Based on your experience in your center, in terms of the clinical condition and also, let's say, hemodynamic parameters like the D-wave, or echo parameters, for you, who would be, which patient fits within the best, parameters, the ideal candidate, and which patient you think is not a good candidate or could be borderline candidate for TRIC1?
So you ask from clinical and hemodynamic perspective. From the clinical perspective, we need to treat symptomatic patients. We don't have evidence with clips or with trick valves to improve the outcomes of asymptomatic patients. So we need to focus on symptomatic. But symptomatics is not only dyspnea. In fact, dyspnea is a late symptom in patients with right heart failure. Congestion is a very predominant symptom. Asthenia is very common. Patients are really tired, even if they don't feel dyspnea and the saturation is correct. Some signs of liver congestion, renal failure. These kind of things are also part of the global symptomatic plethora of symptoms that are in patients with right heart failure. And regarding the hemodynamics, first we should avoid patients with severe pulmonary hypertension. And in patients with borderline pulmonary hypertension and low right ventricular function, we should also be very conservative because the risk of right heart failure is higher. But if the pulmonary pressure is borderline, but the right ventricle is still working more or less correctly, this is a predictor of good outcomes. These patients are very good responders, and normally the pulmonary pressure is going to tend to decrease. Which is the limit? Well, in the trial it was 65 millimeters of mercury. Probably the gray zone is between 50 and 65, and this gray zone we need to analyze very carefully. And then we need to have a V wave that maybe it's not necessary to have 25 of V wave in the right atrium, but if it's 6 millimeters of mercury, of course this patient is not presenting heart failure symptoms. We have to be careful with that because often we do this right heart failure after several days of hospitalization with intravenous diuretics. This is not the good time to evaluate that. We need to discharge this patient and probably do the right heart cath 1 month or 2 months later to analyze which are the true baseline pressures in the right side. It's very low. Home, and it's between 20 or body on the visual.
I think that the connection is not going really good. Can you just repeat just 20 seconds, Ignacio, because I think we didn't hear you.
Yeah, so I talk about clinical aspects, and regarding pressures, I said that it is very important not to evaluate the pressures after a long hospitalization due to heart failure, because patients have been on intravenous diuretics, and you might find low pressure in the right atrium. So when the patient is at home after a month or 2 months, we can repeat that. And normally the right atrial V wave pressure should be avoided about 10 millimeters of mercury. And up to 25 or even 30 is a good candidate.
Okay, thank you. Any more questions from the audience?
I think maybe just one more. Can you hear me? Because
Yes.
my connection might not be so good. One more statement, because I think we have discussed that 20% of the patient had prior pacemaker leads. Of course, we have looked into the fact whether there are any long-term complications with patients that have pacemaker leads, which are jailed between the stent frame and the vessel wall. And until now, we did not get any information about potential lead problems or deduction problems. So it seems that this is very well tolerated. And I think this is also very important also to the Tricus community to report back cases in case that there are any problems with pacemaker leads. As I said, so far we have like identified the patients that have been treated and have started a survey on this with the treating physicians. And until now, we got no reported complications back, but I think it's a very important aspect.
There is a recent publication on tricuspid therapies and pacemaker leads. For orthotopic valves, this can be an issue, meaning that normally there won't be a dysfunction of the pacemaker lead, but a few years ago, it was reported that for valve-in-valve procedures, there were no issues, but 1 or 2 years later, when you trap between the valve and the surgical prosthesis, there started to be some issues with the leads. With a self-expandable device and the native anatomy, I think this is very unlikely that it will happen. It has not happened in our experience or in any patient within the Tricus study, but it's something that we need to keep an eye on, and it's very good that someone is collecting all this information. I think it's very safe for those patients, which are poor candidates for edge-to-edge therapies, because the leads usually difficult the visualization and sometimes will interfere with the system. It's not prohibitive, but it's more difficult. And also we have had experience in one patient to implant a micra, so a leadless pacemaker, which is perfectly feasible after trick valve if that is required and we don't want to leave any lead across the valve or something like that.
Well, I think we can finish for today. Thank you so much, all the participants, for your time. Thank you so much for your statements, and Catarina, Ignacio, super nice presentation. Looking very much forward for the next session. So please save the date in your agenda if you want to check review again this amazing data. This is 16th. Of January, same time, 2 p.m. CET. So thank you so much again, and wish you a nice day and a good rest of holidays. Thank you so much.
Thank you.
Thank you very much. Thank you. Bye-bye.
Thank you. Bye-bye.
Bye. Bye-bye.
Thanks.